Courtney Elker, and I'm part of the Roots Birth Collective and one of the birth doulas. I've been a birth doula for 13 years, and a fun fact about me is that I have 6 sons.
Hi everyone, my name is Melissa. I am also a member of the Roots Birth Collective. I'm a birth and postpartum doula, so I specialize in overnight care for newborns in the postpartum season. A fun fact about me is that my husband grew up here in Bend, and we met in 2015, and he started taking me here once a year until I was willing to move here in 2024. So here we are.
Hello, my name is Catherine Jonas, and I am an IBCLC. I own Cascade Lactation. I do in-home lactation care for the first 30 days of life, and then I also have an office. I really emphasize the intersection of lactation and mental health because it's a delicate time, and really normalize the community of feeding your baby and what that looks like.
I'm Tiffany. I am a home birth midwife. I have been a home birth midwife for my own practice for 22 years. I specialize in babies and pregnancy and birth. Fun fact about me, I mean, everything's fun about me, really. Interesting for sure. But probably I ride Harleys.
Yeah.
And I have 5 children. And I have 2 grandchildren. And there's more, but that's for me.
I know. Kyle. I'm Ellen Easton. I'm one of the midwives at Pine and Prairie Midwifery. I've been working with Allegra for 4 years. Fun fact about her, she was actually my midwife for all of my babies. If you hear a little twang come out of me, it is because I am from the Southern Midwest. And I cannot break that cycle, even if I try to. I've not lived there in 18 years. Fun fact about me, this lady over here, Dr. Holbert, saved my life and removed my uterus last year. And if anyone ever comes into our office, it's in a jar. So it's a great, great teaching tool. I'm going to pass it over to Legs here.
Hi everyone, I'm Allegra Lilly, and I'm the co-owner of Pine Prairie Midwifery. I have been a home birth midwife and have worked and trained in a birth center. So collectively I've done 16 years of birth work. And a fun fact about me is that I love riding my horse and getting out into the outdoors. I tell you other cool things, but that would take too long. So that's one fun fact.
Hi everyone, my name is Tara Holbert. I'm an OBGYN at East Cascade Women's Group. I was just thinking about how long I've been doing this. I started residency 17 years ago, so I've been doing births for 17 years. I also do a lot of GYN. The uterus is amazing, growing babies. But after that, sometimes they can cause a lot of issues. So I'm also passionate about gynecologic surgery as well. Fun fact about me, I was a gymnast. Actually, just Ashley and I, how we connected, our daughters are both in gymnastics, so we're the quintessential former gymnast tiger moms. So that's kind of the fun fact about us right now. Our season of our life is lots of gymnastics. And that's it.
That's wonderful.
Oh, keep it.
Everybody good? Okay, awesome. So before we get started, there were 18 questions submitted. Some of you maybe submitted a question. So it is gonna be like I'm gonna try and prioritize to make sure all 18 questions get answered. But y'all are here. So if you guys have a specific question that you want answered, I want you to have priority. Is that cool, ladies?
Yep.
Okay, so here's what I wanna do. And I'm gonna be keeping clock. I know there's some pregnant moms in the room and bathroom breaks are needed. That's totally cool. If you need to go, just stand up and leave. In about 45 minutes, maybe we'll take a quick break. I don't want it to get too out of control because there is, 2 hours allotted for this, all right? So when we get started here, ladies, if there's a question directed toward you, try your best to keep it within like 5 minutes. I know that one question could take 4 days. I know that because it's just the way it is. So try to keep it within a 5-minute mark. If you have to give a mini dissertation, try to keep it within 5 minutes. Cool? All right, then maybe we'll have a couple of insights from additional experts on the panel, and then we'll move on. Deal? Does anybody in the crowd have a burning question that they'd like to start the conversation off with? Yeah?
Oh, my daughter was
Your daughter has a question?
the only one saying anything.
All right, I'll start it off. Be thinking, write down your questions. Let's go to Catherine first. This is one of the questions submitted directly towards you, Ms. Catherine. If a family is preparing for their baby, why should they consider adding a prenatal lactation visit to their plan?
Thank you for that. One of my favorite visits that I get to do besides just the first time I get to meet baby Earthside are prenatal visits, because there is so much that comes to feeding our babies, and there's many ways to feed our baby, especially if things didn't quite go as planned. So knowing what your options are and what to expect before baby arrives just helps empower families for the other side of it. Your baby has arrived Earthside, and what does that look like? So much time and energy, rightfully so, is put on birth and bringing that baby Earthside. And I tell families that might be 24 hours of your life, that event. But then there is a whole rest of you now that your baby's here. What do we do? What does normal feeding look like? What does abnormal feeding look like? So how do you know when to ask for help? Is this normal? What to expect? And then in the event that there is some cascade of interventions that's going to impact either your milk coming in or mom and baby get separated because someone needs a little bit more attention, what does that look like? And so I don't get in the nitty gritty, but I do talk with prenatals about what does an average feeding look like? It's just drops. Day one of baby coming Earthside, they may just lap at the breast or latch and fall asleep, and that's completely normal. And normalizing that, yes, I'm into this.
Sorry, guys. I don't wear shoes.
But just kind of helping families know, because when you go through labor and delivery, and then your providers, your team of support are starting to make suggestions on how baby might need additional support or mom might need additional support, if that's the first time you're hearing of it, how do you make clear, confident decisions? And do we implement donor milk? Do we implement a pumping schedule? Do we implement other things? What does that look like? And so having that prenatal can help you have that in the back of your mind, and you have a reference packet to look at it and be like, okay, this isn't the first time I've heard of this. And just also normalizing that care changes very quickly. What it looks like on day 2 or 3 is not what it's gonna look like on day 7. So things progress quickly, and helping you understand what that looks like helps you feel confident and empowered through those early days and early weeks of feeding your baby.
That's lovely. Any questions to follow up on that from y'all? Cool. Panel, any comments? Anybody else want to add anything?
And to add to what Catherine was saying, I think it's awesome when we have clients that go see somebody for lactation prior to birth, because it's so helpful too if a client is comfortable with a lactation consultant taking a look at their breasts. Not because they're gonna look at you and say, oh, like everything is wrong with your nipples or breasts, but if you have an idea that you might have a flatter nipple size or a larger nipple size, it's just good wherewithal that a lactation consultant can tell a mama, this is, there might be an extra thing to be aware of with just your anatomy. Doesn't mean you're gonna have an incredibly hard breastfeeding journey. But if there is something that might be slightly challenging and you're a first-time parent and you don't have experience with nursing yet, it's good to have some helpful pointers if something might pose a little bit of a hurdle potentially. And like she said, day 1 looks really different than day 3 or 4 by the time milk comes in. So whatever potential hurdle there might have been might not even be an issue by day 3 or 4. But it's really encouraging when you get some idea about a position maybe being easier once your baby comes out for you based on breast size and nipple shape and size.
Can I add something to that? I love both of these women, and I'm gonna say something maybe a little different, but not that I disagree with them, but also like I feel like if you have somebody come and tell you, and I'm sorry, I'm not.
That's why it's a panel, girl.
I know. But sometimes having somebody say to you like something could be wrong or could be this, sets you up in your brain sometimes for, well, I'm not gonna be able to do it, so you're already putting yourself in a spot. So sometimes, I guess what I'm saying is sometimes, I love Catherine and I send everybody to Catherine, and I think everybody should go see Catherine, especially after having a baby or before. I'm just saying, like, it depending on how you take information in, and if you sit on it, and if you make that your fact instead of what it just may be a possibility, then it could make things harder or worse. But not seeing Catherine isn't going to make anything worse, I promise. But yeah, just putting where is your mind and where's your heart and what are your convictions and what is it that you know to be true, because that a lot of times makes something better and easier or harder.
I was just gonna add to that, we are always data driven in my world, and there's a lot of data showing the more prepared you are, the more kind of work you've done on the beginning for breastfeeding preparation, the more success you'll have. And then also if you have that established person that you've already seen, it's gonna be that much easier to reach out if you're having struggles afterwards. So I think it's so important to do that prior.
I agree with
Great. Kelsey, one more, and then we're gonna go back to Dr. Tara.
Great, I'll be quick. I think this is a theme that we'll see today is when you're talking about experts in any field, we're talking about collecting information. And so for you guys, the question is, what are you gonna do with that information? So if you're gonna see someone to potentially determine if you might have a challenge that you'll face later, you're using that information ideally to prepare yourself and to help kind of bolster the experience, not to move into a place of fear.
Okay, next question is directed toward Dr. Tara. Dr. Tara, what are some important things to consider when preparing for a hospital birth?
Well, as I wasn't quite sure what population we were gonna have here, so I see a lot of doulas, patients who've had babies. I don't know if anyone's pregnant here, but I think it's just good in sharing that, if you're gonna have a hospital birth, I think it's really important, like, considering having a doula for support. All of these women, I see lots of other doulas out here, and really, leaning on your healthcare provider to get all the education and things that you can expect. And if you do a birth preference, I think this was kind of my main thing with this question. If you have like certain birth preferences, making sure you're kind of discussing that with your healthcare team, so they can be really aware and kind of talk about any, considerations that you might want to have for different kind of ideals with your birth preferences. That's all I was going to say about that. Yeah.
I know social media is a big influence today, and we hear hospitals are terrible, you won't be able to have the birth that you want. And I want to say I've walked through those doors with many clients for many different reasons, non-emergent, emergent reasons. I have so many lovely friends who are CNMs and nurses and everybody in L&D here in Bend, and you don't lose your autonomy if you're planning to walk in those doors or you weren't planning to walk in those doors. A lot of women think they're going to the hospital and they're gonna have to fight for their birth, and I can just tell you right now, that's not the case. It really isn't. Home birth isn't your only option. I tell every client that who comes to our door, like, it's not your only option. And you can have support in the hospital setting and still have a beautiful, straightforward birth. So it's not something to be afraid, because OBs aren't out to get you. They really aren't. Neither are CNMs or anybody else. I have supported so many women who chose to be there at the last minute, who had to transfer in, and we haven't had to get up in arms and fight for them either. So autonomy is standard care in the hospital setting and in the home setting and in the birth center setting. So I just wanted to clarify that birth preferences are respected, but sometimes things happen and we have to look at a bigger picture.
Just as a doula that interacts often with the hospital with our clients, we often focus on helping you discover what it is that you prefer, because if you have no idea what you're gonna see when you walk into the doors, even though we have wonderful care providers here, the time allotted is not there to really like unpack or find the thing that you need to find to prepare for. So we help you understand as doulas that walk with you for the whole journey. What does it mean to have Pitocin? What does the head block mean? Where is your cervix? What's a cervical exam? Like, we go over all of that so that we can help you be prepared for knowing what you want to say, because it's really easy for things to happen that you did not expect because you just didn't have the education for it. So at Deep Roots Collective and many doulas here, we bake our childbirth education into our care for you so that it's very personalized and we know what you know. And we also have the privilege of walking with you for your mental health. And so if there's a line that is very important for you for your mental health, we'll use that language. It's like the vaginal exam's not on the table because of your mental health, and we give you vocabulary and help you hold that as a team. We would never be making a decision for you, but we just help uncover it as the doula, like what is valuable to you. And that way when you're there, you can properly communicate it. And practice does help. And so if you've never practiced even saying aloud the things that you do want, then it's hard to communicate it for the first time when you're very emotional, you're actually in physical discomfort, and things are new, you've never seen this person before, you think that they're mad at you and they're not, or whatever the thing is. So I thought I would add that.
That's great. Courtney and Melissa, why don't you just hang on to the mic right there, because the next one really beautifully segues in. This question was directed towards both of you, and it is, how can a doula support a couple before the actual birthing event?
Oh, okay, great. I kind of did just talk about it. Yeah, but before the birthing event, we spend a lot of time with you. We do several prenatals, not just like one 20-minute message. And so we want to help you not only know what is going to happen. So we take, when I say we want to know what you know. We take the baby and the pelvis and we say, Dad, this is what it looks like. This is how the baby has to make these movements to get through and out. And so movement for baby is super essential. That means movement for mom is super essential. And so we connect the dots for you. And this is all gonna help in the hospital setting because we practice laboring at home, but then we transfer it. Like, remember how we labored at home? You can take this and labor and recreate your labor space in the hospital. And so just really getting on the same page. And then as Tara mentioned, birth preferences, we always bake that in as well. So we have like a full questionnaire that we send you and you can like think through each decision. And then we print it for you, laminate it, we bring it, and the staff is incredible at looking at it and really considering what it is that you put there and why. And we feel very comfortable with those things, knowing that we've already discussed them together. And so we chat it up with the nurses all the time because they're incredible and they're on your team too. But we've just had the privilege of knowing you and your inside like fears and concerns for a long time. So that is part of the preparation, is so much education. Yeah.
I kind of wanted to circle back and ask a question, maybe Dr. Tara, in terms of birth preferences, what would that look like in a C-section setting? Are there still preferences that a birthing mom can have on their list, and what would those look like for a C-section?
The panel's asking questions.
I know. Do that? No, I think that's a really great question, and that brings up, we have a birth preference form that we have in our clinic, and there's only like a few questions that people always say, like, I want my significant other to come with me, or a birthing support person, which that's always allowed. A lot of people, if they have a doula, they want to request that their doula comes with you, and that's not like a standard. Usually it's like one support person, but most of the time the anesthesia team is okay with another person. You can have maybe the the request to have it just like a really kind of calm, you know, low lighting. You can have a playlist. We have a speaker in there. A lot of patients like ask, well, can the partner cut the umbilical cord? And unfortunately, that is not ever. I think they tried to make like a drape so they could do it sterilely, but everything's like in a very sterile field, so that the increase of infection's a little bit too high. So that's not really an option at St. Charles, but we definitely want to get the support person or partner involved once the baby is over with the team, kind of evaluating the baby. I guess you can really say like, how much do you want us to talk to you during the procedure, let you know everything that's going on, or do you kind of just want to just be in your own little world on the other side of the curtain? I think the communication piece is a big thing. I usually prepare patients really what they are going to expect for feeling, and if they're feeling anything beyond that, practicing how to voice that, like if they're actually experiencing pain, because I think that sometimes the anesthesiologists don't really quite, they want to kind of, I don't want to say gaslight them, but just like say, no, that's just pressure. And so I really try to help my patients understand, like if they're feeling pain, to be very, very vocal about what they're feeling, so we can make sure that we're getting you as patients as comfortable as possible. So I think really just the birth preference would be setting the tone, knowing who's going to be there, knowing what to expect, and being able to really like voice your concerns, I would say in a nutshell.
Okay. Yep, sorry, again, okay. I appreciate that. And I think that I would like to add that doulas, we have the professional, or the privilege of not being the medical professional, so we get to observe it out of your own body, out of your own experience, and we get to witness it for you. And so there's a huge reason we advocate for doulas that are well trained to be in the OR, and most anesthesiologists allow that. Because we get to witness it, we remember everything, we take meticulous notes so that you know what happened at a certain time, because you are not going to be able to recall the event the same way as you may want to. And so we often will wrap around with you when you're ready. The first visit postpartum is not generally the time where you're ready to unpack your birth story, whether it was beautiful and perfect or it held some hard moments of tension. But we are the continued relationship that goes with you after leaving the hospital, leaving those walls, and we want to tell the story with you, and we want to help you integrate it in a way that feels real to you and not somebody else's version. So we let you lead, but we will be able to fill in the gaps of what was said at a certain time. How did your face respond to that? Like all those little nuances that maybe feel insignificant, they are not, because they are the things that we end up telling each other, right? When we're all walking around with our own birth trauma or stories and we end up landing with somebody that feels safe enough to tell, like those are the things we say. Like when the doctor said that, or when you said that as my partner, like that was what gave me the relief to move forward. Like whatever it is, good or bad, we just get to be there to witness, and that is such an important step.
Okay, can I add one more thing? Sorry. Another thing I think is just important. Again, I don't know like who's pregnant, not pregnant, but whenever you're going into a birth, I really try to educate my patients. There's like, 25% chance that you might end up with a C-section. So really walking through what that would look like and just being like, okay, that's the risk. Obviously, that's maybe not our first choice, but if that happens, walk through exactly what to expect. I was also gonna say, I remember when I had my C-section, I kept texting, or I wasn't texting, I didn't have my phone, but I kept saying like, don't forget your camera, to my husband. I mean, everyone has their phone now, but like taking pictures so you remember, making sure you're doing like skin to skin right away, right, when you're feeling able to. So those are some of the things to think about as you think about a C-section. I think it's really important to be aware that that's always a possibility.
I think one of the things, and it appears to be a theme, is that there can be a lot of fear and anxiety around birth and labor and that whole experience. And I think all of us as professionals get the privilege of walking alongside you in various seasons throughout your labor, throughout your pregnancy, and then even into postpartum. And I think one of the biggest things is that education is empowerment. And the more aware you are, so even just asking that question, I was so curious for myself from your perspective of what are options, because for a lot of people, a C-section is their worst fear going into that birthing experience. Like that's the one thing I just don't want to happen. And so sometimes people won't even go there. I mean, I'll rightfully, like in my experiences, I'm like, I'm not even gonna think about what that could look like because I don't want it to happen. And again, knowing yourself and knowing, will that actually make that fear and anxiety worse, or will it help to have the education, the knowledge of the possible avenues, and then what can be possible in that setting? How can I envision it to be still a, as peaceful of an experience and as supportive of an experience as possible? So I think it is really important to take all this information, understand that all of us, our biggest desire is for you to feel empowered. And so if that's through education of walking through what are my options here, what could happen, with our childbirth education, we really empower both the team, the couple, to understand what is going to happen to your body, the physiology of labor, what's going to happen to baby, how mom and baby work together, the hormone cascade, what is actually happening here. So we're not walking into an event that we feel like is going to happen to us, and that our partner isn't terrified in the corner like, what's happening to her? Because that happens often. So our biggest hope is that you feel empowered through the education.
I'm not saying anything negative.
You're fine, nothing's been negative.
I always tell people, like, if you have a set expectation of the way that your birth is going to go, you're going to be very disappointed, because there isn't one birth that's the same as the other. Whether you've had 5 babies, 10 babies, it doesn't matter. Every single birth experience is completely different. And in my experience, the people that are like, I hate hospitals, I've never had an IV, I've never had a shot, I've never this, I've never that, I'm not going to the hospital to have a baby, we end up transferring them. Because they're not making the home birth decision for the right reasons. And like I tell people, if your heart or your brain believes that the safest place for you to have a baby is at the hospital, go to the hospital. Like, even if every single person in your lineage had home births and that's not something you're comfortable with, don't do it. And don't set an expectation on birth that nobody can promise, because there's no promises in birth, and there's no matter where you are or what you're doing, every birth is different. So going into it with a set expectation is going to disappoint you, and you have a higher chance of struggling with postpartum depression and trauma and all of those things. So just go into it with an open heart and an open mind, knowing that everybody on your team has the same goal, and we're gonna all do our best to get you there.
Yeehaw, you see how fun this can be? We started with a question about getting a doula, and then we heard from 5 experts on the panel about, so this is the beauty of it. The questions are gonna be all over the place, and then you guys and these experts are gonna, let's go, beautiful.
This could be for anyone who wants to answer, but what are some red flags that we should be looking out for when choosing like a midwife or a doula or whoever on the birth team?
Who would you like to answer that first? That would be helpful. You said. Because they all want to answer.
Sure. Okay, I mean, having done this before and experienced both green flags or whatever, beige flags, I don't know all the colors. I would say if you have things that you bring to the table, you get to listen. I always say go in with open ears, because this is your chance to hear what they actually have to say. So the first prenatal is an interview. And so no matter who you're going to sit with for the first time, do not expect that you have to establish care with them, whether it's a midwife, vibe check with us, like it does not matter, but you get to listen. So really come prepared. And then as far as like red flags go, if there's no listening involved on their part when you respond, that's a red flag, because this happens a lot in this kind of work. Is like you can experience a lot of telling you what you want to hear early on, and then the closer you get to your delivery date, things change, and you can really sense that. And so you have to be like a really good detector of energy and personhood. Like what is the kind of vibe that we've got going here? If you're respecting me as a person, that's going to carry through. I always tell my clients, like, make sure to get an experience with this person that humanizes them and humanizes you. If you keep everything like super surface level and you expect them to humanize you, That's not really gonna happen because they see so many people. And so that's another reason doulas are the humanizing part, because we get to be there for all of it, before, during, and after. Even when amazing care providers show up and hold you, like I've seen incredible things happen at the hospital where I'm literally in tears. I'm like, they are incredible. But if you are asking those questions and there's not this like humanizing aspect, I would say that's a huge red flag and probably the most important one. And then like on a more personal level, I love science, I love data, I love knowing the things, the statistics, but if, this is like such a personal answer, so sorry, but like if I go to a provider and I'm expecting a third child and they tell me statistically it's gonna have Down syndrome and do I wanna terminate pregnancy, I'm never gonna come back because you didn't allow me to even humanize my child. So humanizing you, the provider, and the child is an important endeavor, so I'd say that's a red flag as well.
Maybe a little controversial way to think about this, but your provider should never make you feel like you need their permission for anything. They need your permission for everything. So as you move through care, whether it's with a chiropractor, naturopath, doula, OBGYN, midwife, they should always be getting consent from you and coming with an attitude of, we are adding information, knowledge, expertise, and skill to this amazing miracle your biology already does. You don't need our permission, we need yours. I think that's a really good mindset to walk in with that power and authority and understanding who you are. And if that creates a lot of tension, that's probably not the right provider for you.
A lot of it boils down to, are you comfortable with full autonomous care? Like, are you prepared? Not only are you pregnant, but making the choices as a parent now. Because it's very, very important that the route you want or you're trying to aim for and having your baby, you realize you're also making this decision for your child. You don't become a parent once your baby's on you. You become a parent at conception. And like in our practice, I know we look like yeehaw cowgirls, but we see a full scope of people. But in our practice, we're full autonomy. Like everything is informed consent, and you have to be comfortable with the information, the pros, the cons, the risks versus the benefits of making that choice for yourself. And it's really important when we have somebody come into our care, is like, are you ready to take the wheel? Because you're driving the car and we are your passengers. We're basically your airbags. If something goes south, we're there to help keep you safe. It's our job to recognize the abnormal. It's your job to be prepared for what your body can do and the normalcy of it. Anything you want to add?
I mean, there's both of us in this practice. I mean, our practice, I think pretty much every midwife out here, we all have our differences, but we offer everything that a hospital-based provider offers you with tests and ultrasounds, all of it, but we always make sure, we make sure that every client understands that they're not required to do any of it. And that it is a miracle that moms are experiencing, and it's their choice as to which tests they're gonna do and which ultrasounds they're gonna do. So, and we respect that.
I always tell people it really boils down to your convictions. What is it that you want? What is it that you, what are your hard no's and what are your maybes and what are your yeses? Not saying that you should have hard no's necessarily in birth, but you should have a hard nose in autonomy. And if your care provider can't give you what you're asking or you're needing or voicing, that's definitely a red flag. And I was going to say something else, very important, I'm sure.
Just circling back to like how to choose a provider, it's a little harder sometimes with your birth provider, but to hear in lactation, right? I don't take offense if someone transfers care. So for me personally, if I am working with someone and we do, a visit or two, and then maybe someone will tell me I'm gonna go to another provider. Sometimes I get that and I say, of course, like there is vibe checks, right? I might not be your vibe check. Another provider might be your vibe, and they might provide you a different perspective or care. And just in all honesty, there are things that I'm not an expert in lactation. There are times that I might even encourage you to go see a different lactation provider because that's just not my expertise and I'm not going to be able to provide you the full care. So when you are looking for a provider, I think also depending on the nature of it, it's okay to say, you don't even have to say it to me, but go to someone else. And sometimes I do have another lactation consultant reach out and say, hey, someone transferred to my care and can I have your notes? They consented and signed the papers and I'm 100% okay with that. I think if I can speak for us in this one sense, everyone here that I know is just cares about your care, you and your child's care. And if it's us, great, can we provide that? And if you need to go to a different provider, that's 100% okay. We want you to have the most empowering and supportive experience that works for you.
Sorry, you just said.
Yeah, I'm not gonna get in your way, don't worry. And then we're gonna come back, so if somebody has a question, as soon as Tiffany answers, we're gonna come back to the crowd.
I always tell people like, because they're like, well, I'm 38 weeks, like I don't know what else to do, and I always say, are you still pregnant? Then you can change providers. You don't get to do it after it's done. You only get to have this baby one time. And like Catherine was saying, like, it doesn't hurt my feelings if somebody transfers out of my care to somebody else. It doesn't mean they don't like me. It just means that I wasn't the care provider for them. And whatever it was that they chose, you know, and it's not something personal on me. And I tell people all the time, when you tell your birth story when you're 50 years old, I want my presence to be a positive experience. I don't want it to be, well, I couldn't do this because my midwife, or I couldn't do, you know, and that's not my job to tell you what you can and can't do. So just knowing, even if you don't know your convictions, you know, and you don't know exactly what you want, find somebody that will support you, helping you find what your convictions are and what you want.
It's great. Well, listen, we've made it through 4 questions in 40 minutes. We all just like, maybe by midnight we'll be done. This is really, really wonderful. You see, it just kind of like goes. Does anybody have a question right now? After this question, we're going to shift gears off of this topic and go to a completely different topic.
It's kind of this topic, but kind of not. We hear a lot of talking about transfer of care, which as a doula I see all the time. I'm hoping you guys can enlighten maybe some of the families here that are currently expecting or have had babies or are looking forward to it. What should they expect in a transfer of care? Let's say they were planning a home birth, for whatever reason they need to go to the hospital, whether it's at 38 weeks or in the throes of labor. What can they expect that transfer to care to look like? Who becomes in charge? You know, what does that look like realistically for them?
It looks like you have full support, no matter what happens. In our practice, we operate in a pink flag setting, which means we rarely ever face a birth emergency, which they're low to begin with because we only take low-risk women. But anytime we're transferring from the home is where we're monitoring and we're trying to get something to change. And if something's not changing, we look at another pink flag and we get too many pink flags, we know eventually we're gonna hit a red one. If we hit a red flag and we go through those hospital doors hot and heavy, we are lacking choice at that point. Because our goal, regardless home or hospital, is a vaginal birth. It is always our goal, and it's always the provider's goal when we go through those doors. There's not a provider in there who just walks in to meet with a scalpel in her hand. Like, that's not how it works. Like, oh, you came from home, let's just get the baby out now. It's just not how it works in any setting. So like for us personally and how we practice is we go when people are stable, when we still have choice around it. Like, this is what we're seeing, this is why we should go in, this is the tools once we get there that we feel like would be really important to help you achieve a vaginal birth. And honestly, most of our transfers, I'd say 98%, is because of exhaustion, clinical exhaustion. Like, we don't want a mom to be so pooped out that she finally has her baby at home after 4 hours of pushing and then she's too tired to even hold her baby. Like, nobody wants that. That's not the experience mom wants. That's not the experience we want for mom. But very rarely are we like, hey, we have to go right now because this is not good in any point. And the biggest reasons why home birth midwives transfer for any other reason out of clinical exhaustion, most of the time is just because a baby is struggling before they're born. we got a high heart rate, too low heart rate, we've done everything we can in our power in the home setting to get that to correct. And we just want a healthy baby and a healthy mom at the end. And I know we hear that ad nauseum on social media and everything like that, but it is the truth. Like, I don't know a lot of people in this sense, like, I'd rather lose my baby than walk through those hospital doors. I don't know anybody who feels that way. I've never had a client who felt that way.
You always got lots of that. I mean, I could, but Dr. Holbrook, what it looks like with a transfer coming in.
Yeah, sure. At our group, when patients transfer in Central Oregon to St. Charles, they're actually under the care of the St. Charles team because I'm in East Cascade. So it's very rare, but a couple jobs ago, I did a lot of transfers in, and just like what these ladies said, like, we are absolutely still committed to doing everything we can to help you achieve a vaginal delivery. Most of the time, I think that ends up happening with a little bit of rest, a little bit of maybe a little bit of Pitocin. So yeah, that's always the goal. I really think that's it. And then when you're there, we just are starting fresh. We're only gonna recommend a C-section for the normal indications, which I always say the baby doesn't fit through or the baby's not tolerating labor. Those are the two main reasons that we usually recommend it if we can't fix those things. So.
And like I tell my clients, it's, if we are transferring to a hospital, like, you don't need to have your hackles up because we're going there because they have what we need. So your original birth plan of, I don't want an epidural, I want it all natural, I want this, I don't want Pitocin, I don't want third stage management, I don't want these things. Whatever we're doing isn't working at home anymore, so we need resources. So we're not going in there with guns blazing, we're going in there because they have what can help us achieve our end goal, which is getting to have your baby vaginally. And or just getting to have your baby.
And if it ever comes down to leaving home, or if it comes down to transferring a client prior to birth, in either situation, we're reaching out ahead, of course. They know we're coming. It's not a situation where we're pulling up and walking through. If it's that we're laboring at home, we're not walking through the doors of the emergency room announcing who we are. Like, they know we're coming. We have contacted the hospital prior to arriving. So there's a room set up, and it feels pretty smooth to walk through those doors. If somebody is still pregnant and there's something presenting, that doesn't mean that we can even entertain the idea of starting at home. They're going to know who we are. We're going to help our client to establish care. Somebody in the hospital setting on the St. Charles team. And then if it's fine with that client, we're going to continue to do some co-care where they're still established with somebody at St. Charles in preparation for hospital birth. But if they don't already have a doula, maybe they want one of the midwives there when it's time to go into the hospital to have that birth. So they still have support and continuity.
I have a question. Midwives, what's your transfer rate? What percentage?
It depends on the year.
Last year.
But last year we had 11%.
Tiffany?
We've had about one transfer a year for the last, no, that's not true. When I figured it out last, which was 3 months ago, it was less than 3%.
Also yours.
Less than 3%. I had 1 year that was 6.
Yeah, I had 1 year that was I had all primips. And I transferred so many primips, which for exhaustion. So primip is a first time pregnant, first time labor, first time full term baby. And it's just, as some of you probably already know, your first is the longest and hardest a lot of times. And it's just exhaustion that we end up transferring for. And then there's been years I've had no transfers.
I think when you consider working with a midwife, the possibility of transfer is really easy to just kind of shove under the rug. Nobody really wants to think about it. But I want you guys to hear that, like, no home birth midwife wants to be in the hospital any more than you do. Like, we work at home for a reason, and the instances of transfers are emotional for everybody. And that can present new challenges that I can tell you from firsthand experience. Every midwife on this team takes the responsibility of navigating them personally so that they can still hold space for you. So when you're interviewing midwives and considering, you know, who do I want to work with, transfer rate, and maybe what is your threshold for a transfer? Like, what is your tolerance for this situation, this situation is part of the conversation, but also picture yourself in that situation with that midwife. Can you maintain connection? Can you maintain conversation? Can you maintain trust with your midwife in a situation that might be that emotional and stressful, because they're still your lifeline as far as emotional support goes?
Yeah, I think that we had 11%, and most of that was mamas who needed to just get rested with another girl. None of those were life-threatening emergencies. They were first-time mama.
Life-threatening emergencies, I mean.
Are really rare.
Yeah,
rare.
so rare.
I just want to
And
make
like
that
they
clear
were
too,
talking-
that as midwives, all of us know whether, whoever, even if it's not a midwife here, currently on this panel up here today, sitting, like, we don't see everything going, it's very rare to have everything going really, really smoothly, and then out of nowhere, somebody is on the brink of potential catastrophe, or the baby. The most common reason is exhaustion of a mama who's having a first baby.
And
Great question.
adding to the flags, like they were saying, you know, we don't, like in our practice, if we have an orange flag, we're going. You know, we're not waiting until we have 2 orange flags. You know, we might have a couple yellow flags, and we're like, all right, we could probably fix this. But it's always a conversation with our clients, and it's, hey, this is what I'm seeing. How do you feel about this? You know, where would you be the most comfortable? And I have some people that 5 contractions in, they're like, I'm going to the hospital. And I have other people that are like, I'm like, do you want to transfer to the hospital? Am I okay? Yeah. Is baby okay? Yeah. No. Oh, okay. We're gonna keep doing this. And they do it. It's just depending on the convictions of each.
We're gonna shift gears down to the left side of the room, and we're gonna go to a different conversation. For starters, Dr. Ashley, first question, this one will be simple. Why did you put this event together?
I think misconceptions. I want it to be community-based. I wanted you to know there's a lot of options out there when it comes to labor, delivery, childhood development, and that it's not just one lens and this is all that you get. So I wanted you to, remove yourself from social media. Maybe you had ideas or things that came from that, but then I wanted you to get in front of real people that are not AI images, that have real clinical experience and is not just, made up digitally. It's time to get back together in group as women and talk about the things that matter, like having babies. So.
Okay, question submitted for you, Ashley.
Yeah.
Why would a pregnant woman need chiropractic care even if she's not in pain?
Chiropractic isn't really about pain. That's what's out there, but it's really about nervous system and nervous system regulation, which is a really hot topic, but it's always been about that. So if you're not in pain, the cool part about moms that get adjusted all during prenatal, they have shorter birth times, usually right around 30% shorter birth times. They have better birth outcomes, less intervention, they're more comfortable the whole time they're pregnant. And so as far as that whole scope goes, it's more so about comfort and getting the outcomes that you want. Nervous system wise, your nervous system controls every cell, tissue, organ, and system in the body. So why would you not want that functioning at 100% going into one of the longest, stamina things that you're possibly gonna do? You want everything revving at 100%, brain and body, soul, mind, spirit, all of it. So that's why.
Can I add to that?
Yeah.
I'm a mom with 6 boys and a nervous system that's regulated. It's hard to maintain. And I just want to say that the type of care that she does is it's gentle, and I think that that's an invitation for people, because a lot of the work that we're talking about, it's active participation. It's a lot of effort, and it's a lot of mental work to make all these decisions and then maintain them. And so I think that chiropractic during pregnancy is an invitation for rest, and you should take it.
I agree.
What level
Coming to you.
That works too. What level of discomfort or even pain would you expect after a correction, after each appointment? I've heard some people goes pretty easy, and sometimes the adjustments can be painful at first.
Painful at first, I don't know how much pain we're talking. I mean, if you think we're gonna work structurally too. So yeah, we're going to, adjust a bone to get pressure off of a nerve. We're gonna structurally change some things, right? You want your pelvis as balanced as it possibly can, because that pelvis is gonna be sitting there holding a baby, and then it has to go like this for that baby to move through, and then it's gonna come back down. So you wanna open up as much space as possible, but a lot of things, pregnancy is a magnifying glass to things that have actually been going on for a long time. So that's the hard part. I mean, you get pregnant and you're like, oh, now I'm having discomfort here in my low back, or now it's not even my low back or baby, it's actually my neck, or I'm getting carpal tunnel. Like, yeah, that actually was already there. It just was under the surface, like way down here. But now that we're pregnant, the magnifying glass is out and it's showing you. Because I'll see women that had babies 20 years ago, and I'm like, have you ever had this before? They're like, you know what, the only time I ever had this was when I was pregnant. I was like, oh, that means it's been going on that long. So now we're talking about something that's 2 to 3 decades old, and now we're going to address it. So it's like anything else. You're going to go and you maybe adjust a pelvis or mid-back, wherever it is, and then you have tissue, you have muscles that want to pull because there's memory there, right? So this is like, what's happening? I wasn't there before. I've been holding here for 20 years, and now you're telling me to go this way, and this muscle is short and this one's long, and it's trying to find its balance back. So I would say discomfort-wise, going to the gym's not comfortable when you first go. I mean, you're sore, you're uncomfortable, but are you thinking, that was dumb, I'm never working out again? Like, no. So I say give your body a little time, a little grace to move through those discomforts, but then after that, there should be relief that comes to the process, for sure.
Wonderful questions from the audience. Thank you for that. Kelsey, pass that over to Ms. Kelsey. Kelsey, question comes in for you. Your clinic focuses on cellular health for families. Can you explain what this means and how it differs from standard healthcare? Oh, that's a big one.
That is a good one. So, without trying to make too many generalizations, when we look at the standard care that's available, especially for families after the birth, we're looking at symptom management, right? We're looking at, okay, my kid's having ear infections or eczema or some developmental or speech delays. How can we silence those symptoms or those alarms, or how can we try and kind of force the body to correct, whether that's using pharmaceuticals or even natural things. And so cellular healing looks more at that deeper root cause. And it's really surprises, even when I'm working with other practitioners, by the time you or your child have a diagnosable condition, you have 70 to 80% mitochondrial dysfunction. That's really remarkable. And when we look at our biology, the regenerative process where our body heals itself, which is what natural-minded families want, right? Like, we want to experience that really deep root cause healing. That all starts inside the cells. And so when we look at our kids today, we see 1 in 2 have a diagnosed chronic illness. 1 in 2. That's insane. All right. And then 1 in 2 of those, so 25%, have 2 diagnosed chronic illnesses. And I think the really cool thing about what Dr. Ashley's doing today is that started in mom's health way before conception and before pregnancy. And now in standard medicine, we see our kids having asthma or whatever it is, and we're trying to just kind of bottle it up without really asking, where did this come from? How can we support real regeneration inside their body and development so that they're not dealing with all these patches with the leaky boat that's slowly sinking? So at my clinic, that was a really long-winded answer, but I really want to bring in the same model of care of midwifery. So if you've had a midwife, we take care of mom and child together. And I do the same thing. We take care of families together, especially if we're dealing with complex health issues, mom and kiddo together, because the nervous system plays such a big role. But instead of trying to silence symptoms, we're really looking deeper. Like, what is triggering this? How can we support at that really, really deep cellular level? where real health is.
Kelsey, can you tell everybody what mitochondria is? Because she was talking about mitochondrial function has to be, 80% deficit before we start seeing things. Tell everyone what mitochondria is and where it's at. If unless you guys are all cellular biologists, but I'm guessing you're not, so which is okay.
The nerdy dense hat on.
Okay.
I'm a nerd. That should have been my fun fact. I'm a cell nerd. So mitochondria are these organelles that live in our cells. They're most famous for making energy. So their ability to make energy is what allows every single function in the body to happen. But mitochondria also sense for danger. And so a lot of the specific illnesses that moms are facing and children are facing have to do with these mitochondria kind of, they don't have enough energy, and so they're constantly sounding an alarm, telling your body something's wrong, something's wrong, something's wrong, something's wrong. And then we wonder, why is our nervous system dysregulated aside from having many boys? Or high jobs or children or like whatever it is. Sometimes our own body is stuck in this alarm system. And when we can address that instead and bring that energy back up in the body, you guys, your body is designed to grow a baby, heal a baby, feed a baby, and keep that baby alive with nothing but intuition and instinct. And then when there's injury or illness, it's designed to heal, regenerate, and repair. If that isn't happening, it's only not happening because something's in the way or your body isn't getting what it needs. And mitochondria are the part of your biology that are watching for that and responding to that. Does that answer my nerdy question? Is everybody satisfied? Okay.
Kelsey did say a stat that I just want to talk about here for a second. She said 1 out of 2 kids, and out of those, 25% have multiple conditions. The only thing I want to say right now is that's inappropriate.
Yeah.
And it's common and it's not normal. And don't conflate those 2 words to be the same thing, because they're not. I would say even in my practice, one of the things I hear is, well, they told me they would grow out of it. I'm like, okay, out of all the things, that's probably my biggest pet peeve, because the body will grow out of one symptom, but it will grow into the next symptom. So I see it very commonly, oh, they had colic, oh, they grew out of it, and then they had acid reflux, oh, they grew out of it, and then they had chronic ear infections, only leading to multiple antibiotics, oh, they grew out of it, now they have this, gut regulation, oh, they grew out of that, but now they have ADHD, boom, 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 boom. The body never fixed it, it never healed from it, it grew into the next thing. And so these things are common, but they are not normal. And so addressing something in that way at a cellular level and a neurologic level is so important in our day and age.
I have a question for Kelsey.
Yeah.
If you had a child with ADHD, what would be the first things that you would start doing to heal their body?
Aside from getting them adjusted. And without being too nerdy, there's a brain balancing therapy that's nutritional based. It's extremely inexpensive, and we teach parents how to do it, and most kids get relief within 1 day. So we can get kids off of meds. Same with depression, anxiety. We get so many people off of SSRIs and other medications using nutritional therapy for brain balancing. It works for 96% of people, and usually they see results within a day, and the rest of the percentage within 2 weeks. And then I work on cell membranes. So I have tons of free information online about how to repair and regenerate cell membranes, but there's this layer of fat around the nerdy mitochondria and the cells in your body that are responsible for that signaling, and part of that dysregulation that's happening that causes those symptoms.
I'm terribly worried to give you all a break, because then we're gonna have to get back together. Are we cool if we just keep going? Is that okay? All right.
So going back to the pelvis, can you talk more about, let's say someone has tight pelvic floor muscles and is worried about a vaginal birth. How do you prepare your pelvis and your pelvic floor muscles for that?
That's so funny you asked that. I had put the panel together, and then afterwards I was like, I don't know a pelvic floor therapist up here, and I was really upset with myself that I'd already made posters, and I was like, well, I can't go back now. So, from a structural standpoint, I mean, all those muscles attach into the pelvic, into that bone. And so, I mean, once you balance that pelvis out, you are still gonna have tension on one side. You'll probably have some that are not as strong on the other. I think there's a lot of misconception around the pelvic floor, and then the deep core also. I think there's a lot of misconception. Even in my practice, when I work with the lay public, not pregnant, deep core is almost like non-existent because we've engineered movement out of our life. Because we sit so much, deep core stability is like not even there. So it definitely is something that needs focus. I can't say that I speak to that because I don't want to say anything that's not true. I don't give moms those things, but I do give them resources. I myself went through pelvic floor therapy. I had to have pelvic floor release done. I could feel where most of it was tension, and I felt where there's a place where, okay, that's not tension, that's just weak. And after multiple kids, it's more and more important that that pelvic floor is nice and strong before you have that next kid. Yeah.
I just want to add something to that too to bring some relief. Like, most women in today's world are rushing and have so much stress, and they have excessive pelvic floor tension. When you become pregnant, there are these hormones that really soften everything. And so I would also say, like, try not to be afraid, because your biology really knows how to soften and respond and prepare for pregnancy, and that really comes at the end in a pretty remarkable way where everything kind of just softens and opens. And so persistent pelvic floor tension, in my experience, I'd be curious to hear what other midwives and what you think, but I feel like it's often related to emotions and stress and trauma. And so prior to pregnancy and during pregnancy, really doing like somatic release, even with the bottom of your foot, the fascia into your pelvic floor starts at the ball of your feet. And so rubbing your foot over a ball and doing the fascia relief all up the front, and like the somatic and emotional work can make a really, really big difference in as far as like tension in the pelvis inhibiting birth. But most of the time, your body's deciding to have a baby, you're just gonna have a baby.
Anyone else might be able to? Was your question more directed at worrying, or not necessarily worrying, but were you asking in the context of babies coming through the pelvis, or just having tension prior to birth?
I think more, how can you prepare your body? You know,
Just
if
more
you have
preparation.
pelvic floor therapy in the past, should you go again? Should you stretch out the perineum? Like, what should you do?
Yeah, no, thanks for clarifying. I always think it's not a bad plan to just have an assessment done by a pelvic floor therapist if you're thinking, you're curious about like what's the baseline. Absolutely, emotions play a part. You know, what are we carrying? What are we holding? That can impact how our baseline constitution is in our pelvic floor muscles. And if you've seen somebody in the past and you have a good baseline for yourself, it's not bad to check in again with somebody just to see where am I at now, even though I've done some work in the past. General movement in pregnancy, I think, is really helpful. And I've noticed, not that this is true of everybody, but general movement and wellness as far as getting out and walking and gardening and yoga and things of that nature are really helpful for a good baseline in our cores as well as our pelvic floor. As you're, like Kelsey, both of you were saying, like our cores are important as well as our pelvic floor health. But there's sometimes unintentionally so much movement and focus on like strengthening. And we do need the ability as women to have that softness when it comes to releasing and allowing a baby to come through our bodies. That there can sometimes unintentionally be an overfocus on like strengthening our bodies. So there's a fine balance, I think, that sometimes unintentionally some women maybe are pushing themselves too far one way or the other, and just generally moving is so healthy for us. And it doesn't have to be a set amount of hours of like really intense working out to achieve what we need. And that's what I've noticed as a provider over the years. Like just really getting that general movement is wonderful.
Yeah,
I know
well,
you do too.
I'll just say really quickly, yes, the pelvic floor is so important for women, but if you have concerns with a tight pelvis, we have amazing pelvic floor physical therapist here in Bend, and it is so important to prepare, and they will prepare you for birth. Because we do see in childbirth patients who are wanting to go unmedicated, and there could be that fear component, and we hold all of our attention in our pelvic floor. And that is actually can cause labor dystocia, the baby not able to get down. So sometimes I purely recommend an epidural just so you can relax your pelvic floor. So if you can do that work ahead of time and know the difference between strengthening and relaxing, that's gonna help your birth so much.
I was just gonna kind of say the same thing, as just like getting a pelvic floor therapist in pregnancy. You know, everybody thinks that you should get a pelvic floor therapist after pregnancy, but it's so beneficial to do it in pregnancy as well. And going off of the emotional thing when it comes to the pelvic floor and a tight pelvic floor, we tend to hold any kind of sexual trauma is held in our pelvis, and that can keep the muscles from relaxing. But also I just wanted everybody to know that they're muscles, and muscles are amazing. And I have been completely blown away by women that I was like, oh my gosh, how's a baby ever gonna come out of there? And they do it without a tear. You know, it's muscles stretch and muscles go back and muscles, you know, I think a lot of it is definitely emotionally based, not saying that there's not real like pelvic floor tightness, but a lot of times it's, you know, some things that we need to work through ourselves and not overly think about how am I gonna get a baby out, because you're placing that doubt in your body already.
Doula, we often get people that have experienced loss come to us, and we're like the first people that hold that with them. And so I would just emphasize that whether it's loss or sexual trauma, like invest in a birth team that you can safely share that with, because we do see it a lot. We can tell if there's something that's not been shared in the way that labor progresses and happens and unfolds, versus like somebody that's very self-aware who says like, this is my story, this is my, you know, demographic that I'm coming to this with. And the surrender from naming it, and the surrender that happens when you identify it and then surrender to it, happens inside of your body in response. And I've seen first-time moms with that as a history, it just goes so well because that work has already been done. And so, you know, a lot of the times we say it's 80% mental, and that's pretty much always the case. And a lot of the work has to be done prenatally. And so I just encourage you to do that.
Real quick, not to overlook the obvious thing either, which is breathing. If you grew up in the 90s where like there were those ridiculous low-rise jeans, we all learned to like suck in our gut and walk around with our ribs flared one way or the other, and that destroys your pelvic floor. So, you know, like you have a beautiful belly, let it be the way it is and breathe with it.
I love it. I will just add anecdotally, as someone with a tight pelvic floor. One of my care team very gently helps remind me, and the funny thing is that because of the nature of the work that I'm in, I get to see my care team often, and I just go through life, and then I'm like, it's okay, it's doing fine, and then I see them, and they call me out, and they're like, I'm doing our proactive work to help our pelvic floor, and I go, great, I will go do that homework tonight. And so having your team, literally every time I see my chiropractor, I'm like, oh, that's a great time to go back and do my pelvic floor work or my pelvic floor physical therapist. But your care team is like a good, gentle reminder. And I know that I'm busy and I go through life, and that gentle reminder, whether I see Dr. Ashley's face on social media or in person or share a client, or my chiropractor, then like I get to, it's like a nice gentle reminder for me to take that time to focus on myself, relax my pelvic floor, and I need those reminders. I don't know about anybody else, but it works for me.
I'd like to add, we talked about red flags and providers. There are red flags in pelvic floor therapists, as I'm sure midwives have all experienced. But if a pelvic floor therapist says, yeah, your pelvic floor is nice and tight, you're great, I don't need to see you anymore. Or if your pelvic floor therapist says you could never have a vaginal birth, please go get a second opinion. Please. There are so many incredible pelvic floor therapists here in Bend. Insurance aside, it is your body, it is your birth, and you should treat it as such in a way that you want to get to the other side. Because I have been inside a woman's body trying to help them push the baby out when they have a pelvic floor therapist, tell them they have a strong pelvic floor, and when they push, they literally suck my fingers up their body, and when they relax, their baby moves down, which is the opposite of what we want when a mother is pushing. You don't want baby to go up with pushing, baby to come down with pushing. And I can tell you in all of those cases, they have seen a pelvic floor therapist who either said, I doubt you're gonna have a vaginal birth, or your pelvic floor is tight, you're perfect. So please keep that in mind for any pregnant person or postpartum person who wants to see a pelvic floor therapist. Like, there are red flags there too.
Any questions from the group before we go on to, we're gonna go back into breastfeeding now. Anybody have anything?
Can I just like throw a wrench in it for 2 seconds?
Wrench it.
Yeah, wrench it. We'll get to breastfeeding.
So
started.
Ellen brought up something like very minorly, which I don't think is what she was meaning to bring up, but insurance dictating care. You guys, if you have the ability in any way to plan to choose your provider based on what's best for you, instead of what your insurance dictates, I think this is an important conversation that we're not here today to have. But I can tell you from the provider perspective, the way that insurance can limit the care that people get is unbelievable. And if you have insurance that covers the care you need, that's great. But just do not make your decision on your birth team based solely on insurance. Like, it can be a factor, but you need to really decide like who your team is based on, and we've all been there. Like, I personally know a lot of women on this team who have had to get real scrappy to pay their chiropractor or their midwife or whatever. Like, every parent is in the same boat. But the injury of letting insurance dictate your care is not worth it.
Okay, this is a general question. I think that each of you women will have some valuable insight on this one. It is not directed at anyone specifically. What are the most common breastfeeding challenges and how can they be prevented? Just so you know. I think everyone maybe will get some good insight on that.
Yeah, you know. Great. You all can share afterwards. So literally the most common that I see, that I hear about, that I try to prepare women for is something called engorgement. Engorgement, while common, is not normal medically. What it is inflammation. And what that is someone who sees a lot of these lovely midwives, and I see their mamas on day 3 or 4 of life, or if you're an established prenatal client with me and I see you day 3 or 4 of life, commonly that inflammation, no matter how we bring a baby earthside, there is trauma on the body. And that inflammation is processed by the lymphatic system. We have huge lymph in our armpits and in our throat, collarbone area, and then it's processed by the heart. And our glandular tissue, our mammary tissue, behaves like overflow lymph when our body is sort of like, okay, what do we do? There's a lot to process on the body. So commonly that inflammation settles in our breast, and that makes our breast hard and taut. I commonly hear women conflating my milk is coming in with hard, taut engorgement. Those are 2 different things, although they sometimes happen simultaneously or close together. When I'm seeing women, and what I like to prepare them for, because while it sometimes happens day 3 to 4 before I get there and I can help prepare them for it, sometimes they open the door and and they can't move. If we have a hard, taut breast, oh, I wish I had my boob over there. If we have someone throw a boob. David, can you throw me my boob? Yeah, can you toss us the boob? Thanks, David. I love you too. Thank you. Guys, my mom made this. It means a lot to me. Okay, I'm gonna try and do this. Okay, okay, so most women, when we're teaching breastfeeding, they think that baby latches onto the nipple. That is not what we want, guys. Okay, thank you. This is spicy. So what we actually want is the baby to cradle the nipple in their mouth and cradle it, but when we are hard and taut, the baby's just gonna go shallow, get on that nipple, it's gonna cause nipple damage. It's gonna cause nipple damage, and this is painful. We're also inadvertently, the baby is cutting off the milk getting to them, so we see slower weight gains when we have this. Most women feel this is supposed to be painful and uncomfortable. It's not. Getting used to breastfeeding, there is some soreness associated with it because, like, let's just be real that this is the most action our breasts typically get. So that's a lot of action. We're going to 8 to 12 times a day that someone is latching on for 20 minutes at a time. There is going to be some sensations that are maybe just like uncomfortable, but we don't want to normalize pain. So what do we do with engorgement and how do we help? We treat the inflammation. Ice packs, breast gymnastics. Does anybody know what breast gymnastics is? It's my favorite thing ever, guys. Basically, we're going to move the breast tissue and allow that lymph to move back. That little tidbit of ice, ibuprofen, if that works in your family care plan to reduce inflammation, breast gymnastics, that is going to go a long way to having you have comfortable feet. That's the most common thing I see on day 3, 4 of life, and just a little bit of being proactive can make such a big difference in how those early days of starting to feed work for you and your baby. And there's many more, but anybody else want
that? What I see a lot of times is just people going into it, moms having babies, but not preparing for postpartum. They think, oh, once the baby's born, I'm on cloud 9, I have a new baby, everything's gonna be perfect, and really you're dripping milk and you're crying and your body hurts and you haven't slept in days, and and you're like, why won't this baby eat? I can't feed this baby. So just preparing for postpartum and getting a good postpartum team, lactation consultant, doulas, your mom, your sisters, the people that are gonna support you the most, and having a list on your counter of house chores. So when they come over and they say, what can I do for you? You say, there's a list on the counter, go do as many as you can. And then it's not you necessarily saying, hey, can you do my dishes? I really need my dishes done, because that doesn't feel good for us as women. But if you have a list on the counter and they're like, what can I do to help? And you say, go check out my list on the counter. They're gonna do the things that they have the time to do. And a lot of people don't ask to help you if they don't want to help you. So take the help. Let people love on you during the postpartum period.
I'd say the biggest thing that we see is we walk into somebody's house at 24 hours postpartum, 3 days or 7 days, and they're just like, how do I know if my baby is getting enough to eat? That is the biggest thing I feel like most of us midwives face, like, how do I know? Because it's not measurable. Like, you're feeding your baby from your body, and you're like, I have no quantifiable amount that I'm feeding them, unless I'm bottle feeding or I'm syringe feeding. And the biggest thing in WIFRI that we prepare for is that your body is incredible and it knows what to do. And yes, there's some hiccups with babies with tongue ties or maybe nipple size, but we navigate them. I can't tell you how many times, I don't even think we know anymore, Catherine, I've called you at 10 or 11 o'clock at night and I was like, hey, at 6 a.m. can you please go to Madras? Because like, we need help, girl. We have a baby who's losing too much weight, and we have done everything in our power and our knowledge to get this figured out, which is why we love Catherine, and she always answers our phone calls until one day she probably won't. But that's the biggest thing we see, and we counsel mothers prenatally before postpartum, so we're not faced with this, that our bodies actually produce breast milk every 20 minutes. It is not hours in between, it is every 20 minutes because your milk supply comes from your blood supply. And you still very much have a blood supply after you have a baby. Which is like the biggest thing at Tiffany's that I went on to is education. We have so many moms prepare for labor and birth, and most of the time that's just a day. Your postpartum is 9 months. An elder midwife once told me, and it changed my life, 9 months in, 9 months on, 9 months near. You have an 18-month postpartum because your baby needs you very much so for the first 18 months of their life. So it's important to prepare yourself for 18 months after the birth and not just focus solely on labor and birth, so that way you're not set up for failure when challenges do come. Because all parenthood is survival. I can tell you, I have 2 feral farm boys. You do not parent them, you just try to keep them alive. And that is why I am so tired all the time. And that is why I have haggard tattooed on my arm, because your girl's haggard all of the time.
Can I add something, or you can add something? Well, I'm just gonna say it aloud, to the point of blood supply. Maybe this is the only time you'll hear this, but if you experience postpartum hemorrhage, that changes your blood supply, and that often affects your milk drainage.
Which good nutrition and lots of water, hydration.
Iron.
Neurologic development wise, breastfeeding, you have 2 boobs, so you really want that baby going on both sides, side to side, and sometimes range of motion in the neck, the baby can't do it. So if the baby was assisted in any way coming out, especially C-section, because when you have a C-section, you pull against gravity on the neck, and it can get up to 90 pounds of axial traction, like 90 pounds of pulling. And so when that happens, one of the first misalignments that happen is right at their C1 and C2, right at their brainstem, and they can't get that full range of motion right there. And it's almost like they have a whiplash, not almost, they have a whiplash injury in that area. So you have to be real certain that they have that full range of motion. And then nobody talked about tongue tie. Thank you, Kelsey. Someone has to talk about tongue tie, because it's everywhere right now.
I was gonna say, just tension with tongue tie in there. But you guys, I don't know how long I was practicing before I learned some tension release exercises from Dr. Ashley that I brought into my own practice and worked with babies right after birth, and then send them to Pangea because they can do a million things that I can't do. But even just those 3 or 4 small things I learned from Ashley have changed the first 3 days of breastfeeding for all of my clients. Like, if you think about what that baby goes through, like, how do you feel when you sit in a weird position, right? Like, your neck is tight, you're sore, you're uncomfortable, it makes you moody, you're exhausted. Like, babies experience headaches. They experience pain, like, from the bruises. They experience all the same sensations we do, they just can't communicate it. And that tension, when it's, we'd say, like, more normal birth tension, still really impacts breastfeeding for mom and baby, because if your baby's kind of tight and uncomfortable in one position, you're naturally going to mirror that. And then that deeper layer is tongue tie, and this I think comes back more to some like genetic changes and nutritional deficiencies and mitochondria things happening pre-conception as well. So really taking care of yourself is really important, and I think everyone offers education on that, right? Yeah. But sometimes get it evaluated like 24 to 36 hours. Doesn't mean you have to do anything, but at least understand what your baby's tongue function is like, so that you can take the steps to get at least the body work, and go from there and see what happens.
Yeah, go. It's like nobody.
And it's also just really important to remember the first couple of days after baby's born. Everybody has colostrum. You're not going to have full milk supply. And it can be sometimes a little frustrating feeling when baby's cluster feed, or you're thinking like, is the baby getting enough to eat? The baby has a teeny tiny belly. And I always like to try and remind everybody of that. Like, you know, in your tiredness, you might have just forgotten, like, I don't have full milk supply yet. Days, the 24-hour visit, when we come in, 1 to 2 days life looks really different once the full milk supply comes in. And when it does come to newborn exams, we always evaluate, does the baby have a tongue tie when we're looking in their mouths? If we're concerned, we talk to our mamas about whether or not we think it's something that we might be helping them to work with at those in-home postpartum visits, and recommend evaluation, recommend getting them into chiro. If we had to do maneuvers to get the baby out, that we know we put a little more pressure on their shoulder because it was a shoulder dystocia, or something needed to happen to help them be born. We talked to them about that, like, hey, there might be some soreness right here going down baby's neck, or if they did need a surgical delivery, because we did everything under the sunshine to get them at home. There's going to be maneuvers that a provider needed to do in the hospital to get them out safely. Like, sometimes there just needs to be something that happened. Let's point that out to our clients, remind them where they are stages of milk production, and know that if it was a tongue tie that happened regardless in the womb, and there was maneuvers that either the midwife or the provider in the hospital needed to perform to help baby arrive safely, let's work with those two things and know that by day 3 or 4 when your milk supply is ending, it could look really different as far as how the lash is feeling, even if there's a tongue tie present. So it's good to identify the tongue tie, but know that it's not the end all be all. There might not be a reason to correct it. Once there's a supply established, the lash starts to improve, and the way the tongue works differently, the muscles start to release. If chiropractic was used, that picture could look really different. So,
Oh yeah. Well, so I mean, tongue tie. Yeah. That's like a big part of my practice. It's not something I want to be part of my practice. It is not what I want for families. There's tongue tie. It's becoming more of a thing in lactation world. You know, it's interesting. Is it a new thing? Is it a new fad thing? Is it just getting better diagnosis? Is it an easy out to address what's going on with the dyad of the family? We have really interesting historical references for midwives in both the Middle East and in Ireland who kept really great historical information on them slicing tongue ties with their sharpened pinky at birth. So it's not a totally new thing. It has been being addressed for hundreds of years. Just kind of, we lost that when we started having more hospital-based births and men took over, really 130 years ago. So, you know, we lost a lot of that historical knowledge, and then it's kind of coming back, and we're seeing some great releases, and sometimes it's not the whole picture. So what is tongue tie? Basically, it's fascia. Everyone has a frenulum under their tongue, and when we are evaluating tongue tie, we're either looking at what position the tongue tie is. So is it the tip of the tongue? Is it more towards the back of the tongue? And the level of restriction and function. A good, savvy tongue tie specialist is not going to move to release that tongue tie right away. The first thing, because it is fascia, y'all, I could just the reason why I love this care team is that we are all aligned that body work makes a big difference for both mama and baby. If you think of baby softening that cervix with every single contraction and push, if there is even the slightest tilt of that head, and then they're experiencing these intense contractions, or there's interventions to help bring baby safely on Earthside, that tension is still going to be there. They're so delicate. Both babies are both so delicate and so sturdy. It's the beautiful thing about babies. And when we just let me tell you a story about a mama that I showed up day 4, and baby had this crazy visual tongue tie. I was like, oh my gosh, mom's nipples must be completely wrecked. And she's like, no, supply is good, baby's gaining. And I hold this baby, and I'm telling you, this baby is like Jello, which is not what I see with tongue tie, because tongue tie is fascia. We typically see these really stiff, rigid babies. I started asking mom questions. Did you get body work while you were pregnant? What does that look like? Do you plan to get body work postpartum? It's kind of my entry level, because some people, when I say chiropractic for baby, they look at me like I have 3 heads. So I kind of ease into these conversations, and no lie, they said, doctor actually saw me yesterday and baby. And that I would not have been able to tell, because that early intervention with chiropractic care on baby. And so it makes a big difference, because it is fascia, a little bit of time, but good quality body work. Let me just really emphasize quality body work. Whether that's cranial sacral, infant pediatric PT, or infant certified chiropractic care, then that makes a big difference in helping that baby relax into those positions that might be a little spicier for them. My number 1 red flag is when mom says there's a difference between sides and pain. So if baby can't go both sides, there is something structurally that's impacting their ability to feed comfortably, and they're taking that tension out on mom when they are latching.
That's great. So we're under 20 minutes now, and I want to make sure that every single one of these experts has a moment to really share with you something they're passionate about. So what I want to do, panel, is I'm going to give the mic on one end, and we're going to go through, If I start creeping toward you, it's not out of disrespect, it's just that I want to keep it moving so that people don't lose an opportunity to hear from you. So, the question is, what is one thing that is misunderstood about your profession and your role in your profession? And what can you do to enlighten us all about that thing that maybe is misunderstood?
Oh, I love this.
60 to 120 seconds, so
Okay.
1 to 2 minutes max.
Well, I think that Ellen kind of touched on it, is that thinking that OBs are just like out to kind of get your baby out quick and dirty and get, things done. We want what everyone else wants here is you to have a very non-traumatic, satisfying birth experience, healthy mom, healthy baby. I'm very passionate about prenatal education, all these things these women have shared. So it's actually been really enlightening for me just to like really see how much on the same page we all are.
Let's see, what's a myth I can think of? I mean, there's lots of myths out there, but I mean, honestly, it's something that I have seen historically over time is that midwives, we don't necessarily have like a consistent, deep, well-grounded educational path. I would say that is probably not true of most of us. I can't speak to every midwife everywhere. There are a lot of different educational paths for midwives, that is true. But I would really confidently say a majority of midwives, whether they're licensed or not, come from a really focused background of training under another really experienced midwife and doing self-study that's followed closely, or coming from an established institution of education and then doing an apprenticeship piece. Either way, they're being really closely followed as far as how their skills are checked and then verified as far as their ability to perform those skills safely and manage their performance and those skills outside of being watched over by a preceptor or a senior midwife. So by the time many of us are done with our educational paths, whether it's one of the two I mentioned, you're probably looking at 6 to 7 years of education and experience at births underneath somebody else who is far more experienced themselves at attending births. By the time you graduate a program, it's not number of hours you attended witnessing births, it's number of births you did. And so, I mean, many of us see a couple hundred births minimally by the time you're practicing on our own. So thousands of hours of births by the time you're actually doing it on your own time.
I got a fun one for y'all. So where I'm from, home birth has been illegal, meaning you will be imprisoned up until 2023. So I'm a black sheep in my family, having a home birth. So I just really leaned into that hard. I let my mama know it's 2,000 miles away. Like, I go to a hut. She has dreads, she wears a cloak, I get saged every time I walk in. I try to buff her up this, this is some witchy woo-woo stuff. And when she did finally meet Allegra, she about smacked me upside the head and was just like, I cannot believe you lied to me like this. Which was great, it was so much fun. But I think the biggest myth is it's not safe, that birth is inherently not safe, which is wild from my background because I grew up on a 6,000 acre farm where all we did was see natural normal mammalian birth. I have intercepted with birth for animals 5 times in 18 years. All I saw was normal, but yet me, human, mammal, giving birth at home to my entire giant family was so asinine. So much so that I got a comment, well, what if you die? And I was like, well, I'm not gonna have opinion if I'm dead. So I'll let you write that Google review because I'm not gonna be able to. And it's important to realize that, much like Tiffany said, we don't know what path birth is going to go down. And I tell everyone who comes and sits before us for a consult, I cannot guarantee you a home birth, and low risk does not mean no risk. And I wish I had a magic ball I could shake that says, yeah, we're gonna take 4 left turns before you get on the right track. I don't have the ability to do that. We're here to ride it out with you and figure out which way it's going to go. But I think the biggest myth around it is that we're just willy-nilly sitting in a corner knitting. when that is not the case. I have held women in my hands face to face, and we have cried tears together to get them on the other side of what emotional hump we're stuck on. I have unstuck babies. I have jumped into a birth pool to deliver a breech birth. That was a surprise. But it's not that all of these things are inherently dangerous. We just maneuver and work with what's happening in the moment. So it's important when you're finding a provider or you're thinking about birth in general, is just to know it can go 81 way. And no matter how much you prepare, like Tiffany said, we cannot guarantee it's gonna go that way. And I tell everybody, do not put your birth on a pedestal. Let it be what it's gonna be so you can be surprised at the end in a pleasant way and not a negative way that I wanted to do this and instead I cussed the whole time, or I almost stabbed somebody with a birth comb. Because these things also happen. I can't tell you how many times I've had to like dodge a leg in the face because the mom's pushing and I'm like, goodbye world. So it's just important to realize it's not gonna just be quiet. Maybe you are a quiet brother. Maybe you're screaming out at your midwife or talking to a past relative who's been gone. Like, just let it be what it's gonna be and know that your care team, they've got you. And that, I still think it's ridiculous. This is illegal in so many states. So I'm gonna end it on that before I get on soapbox.
I would say probably, one of the biggest questions that I get is, well, what happens if there's an emergency? And I always say, well, I throw my hands up and I say, well, you're on your own now. I don't know how to do this, which isn't true, of course, because we're trained, like I was saying, like we have a lot of apprenticeship years, which is a lot of hands-on. You know, it's a lot of getting dirty up to your shoulders sometimes. You know, it's a lot of tears, a lot of no sleep, all these things to get you to a place where you're like, I don't want to deal with these emergencies, but I have the ability and I have the skill to deal with these emergencies. And I'm not gonna put myself in a situation where the emergency is so big that I should have transferred to the hospital 2 hours ago. You know, that's not what my specialty is. My specialty is normal physiological birth. When it goes outside of that, that's not my specialty anymore. But also, like 96% of the time, normal physiological birth happens if you just let it be normal physiological birth and not something that's managed. And sometimes I do sit and knit. Actually, I don't, because I don't know how to knit. But I have moms that are like, you can sit in the hall, I'll tell you when the baby's born. I say, okay, I'll be right here. You got popcorn or something? And then there's other moms that, like she said, you're in the birth tub with, because they're like, I need back pressure, and you can't give it the way that they want it, and they're screaming at you, get in the tub! Okay, I'm coming. So I would say it's just the myth that midwives don't know how to handle emergencies. We don't want to, but we are skilled in emergencies if we have to do
What's up with the lactation? That maybe that lactation consultants, sorry, we have a branding problem. Let me just share with you that as an IBCLC who got my master's certificate in lactation, human lactation, and I have my BS in human development, we are infant feeding specialists across the board for the first year of life. So whether you are exclusively bottle feeding, pumping and bottle feeding, formula and bottle feeding, combo and bottle feeding, introductions to solids, potential allergens, things like that, we are informed and educated on all infant feeding up to 1 year, and then any breastfeeding that continues beyond that. So if you are breastfeeding for 2 to 5 years, obviously like I can assist with that. I probably don't at 5 years, but you know, I'm here if you need me. But really and truly, IBCLCs are a useful resource in the community, and because we have lactation in our brand name, which I do feel passionately about human milk for human babies, there are reasons, and I support families regardless of their choice to feed their baby, and I am here to help you regardless of what difficulties families are facing.
I just wanted to impart a piece of wisdom that I learned years ago that I think has been really valuable for me in my personal life, as well as to share with my clients as a doula. It's that 2 things can be true. You can have you can have a difficult labor experience and still be so thankful that your baby's here. You can have beautiful children that you love so deeply and desperately need support and a break. I mean, you can the list can go on for forever, but I just think so often in our culture and our society where we are constantly seeing messages being shared of that something has to be one way or it has to be the other. That's my soapbox, is I am very frustrated that new moms are consuming so much of that because we are already in a state where everything feels new and uncertain, and we are like infants ourselves trying to figure out this new version of ourselves, navigating the relationship with our spouse in a whole new way, keeping this new human alive, and we don't need all that excess messaging. So if you can just remind yourself constantly that with any strong feeling or conviction you're having or challenge that you have, two things can be true, and that's okay, and you can be a great mom, and you've been wanting this baby for years. Maybe you struggled with infertility for 5-10 years, and you finally have this gift of this baby, and you should be so thankful, and you are so thankful, and you're struggling, and that's completely okay, and then you have people to reach out to when you need it.
I could go in many directions. I guess this is an opportunity to say that I've been a doula for several years, 13 years, and doulas specifically are in a very unique position. We are not medical providers, and you know, midwifery used to be more traditional, and then it's become licensure. And so I'm just going to speak not for all doulas. This is just my perspective, and I won't own it. But like, I don't believe in licensure for doulas. I think that we get to be outside of the system. We get to hold your personal beliefs and your stories and witness you, and then also help you in your advocacy. And so I've never been somebody to like kind of go underneath an umbrella of doulaship per se. I always encourage people to follow your passions. If you want to be a doula, or if you enjoy being that kind of support person for somebody, that you can create the type of doula you want to be through Rebozo, in like structuring your own package, essentially. Like, be compassionate and do all these different certifications if you want. I think that's really valuable. But just doula oversight in general, or to the point that you were making, like, what does insurance say that you can and cannot have? I do not agree with that, and I think it's important that you know what kind of doula you're after. Yes, I love when doulas can be covered by insurance, but it's just not always possible. And then also you'll see our booth out there. It's now a 501c3 in Oregon, and our hope and our heart is to be able to circumvent that issue of like, you can only have one way, because we all function differently, and that's great. Like, we all have great relationships with one another, but being able to access the care that you personally need, regardless of what insurance says you can access.
Will you say that a little differently? That's super important. I think other people would be like, why wouldn't you want to be certified? Why wouldn't you want to be recognized? And it's because you want to not be told what to do. Yeah. And so I think, like, I just want to say that a different way, because,
Yeah, and it's not like, it's because it's all client-based. It's not on my preferences either. I serve so many people that have a different opinion than me. But it's just like an institution.
Oversight restricts you giving your client
Yes.
what they need, not you
Yes.
getting what you want.
Correct, yes. And I think it's important that doulas stand their ground, and that we kind of like don't let it get taken over as a whole. And so part of our job as the collective that we are here in Central Oregon is to also legitimize doula as a real career that it's kind of been belittled for a long time, and it's the most valuable. Yes, midwifery and OBGYN, everything's so valuable, but I mean, I really believe that like, you do deserve to have support that you know in the room that can be there for witnessing you, and I'm not being told how to behave necessarily by policy or anything.
For that. Andrew, I think that's a tough question for me, because I don't know if there's a lot of misconceptions about what I do, because I don't know if people really know about what I do. I'm in such a niche with cellular healing and family health in this really holistic and natural way that I think people just don't even realize it exists. Like, you do not have to be funneled down to either like this extreme rabbit hole of like, 5-minute pediatric visit where you get a vaccine and antibiotics for an ear infection, or you're told this is just your kid is, and then you leave, or this extreme of like you never see any provider for your child ever because you're so scared and you don't trust anybody. Like, I think that one misconception I would say people have with working with me is they think they're gonna come in and get like a herbal or supplement protocol and then leave. And it's not that I don't offer that, but it's that the way that we work is so much like midwifery. Like, I want to empower parents to be more independent in managing their family's health. And there's so much powerful knowledge and wisdom and tools that make a bigger impact. You guys, like, I work with really, really, really unwell people and they get their life back. Imagine if you took those same tools into your home and managed your family's health that way. So I think I would say the biggest misconception is instead of just telling you, take this, I'm teaching you and mentoring you like a midwife would prepare you for birth, to prepare you to manage your children's health in a holistic way that nurtures them at the cellular level and beyond.
I was listening to everybody else, so I didn't think about, what was the question? Misconceptions about your profession.
What is something that is misunderstood about your role in your profession you'd like to share with the group?
I think when people think chiropractic, it's all neck pain, back pain, pain, and it's not about pain. Pain is just a signal. It's really about function. It's about adaptability. And the thing that would make somebody unwell is really their inability to adapt to their environment. And so what we try to do is to get them to be able to adapt again. So even when it comes to kids, a lot of times it's when there's so much neurologic interference inside, it's like Metallica is just playing like as loud as it can. And when that happens, you can't take in this external world, you can't process everything that's happening out here. And so when we go and we start working with, kids or adults, it doesn't really matter. When you go and start working with those people, you're trying to take that Metallica and turn it into classical so you can function and process what's happening out here. You get it. All I would say is I think it's easier to grow a healthy child than it is to fix a sick adult. And so starting right now with this conversation here in this moment, no matter where you're at, is like the best time to have this conversation and start it. So.
Wonderful. Well, we are at 2 hours. Dr. Ashley, if you want to give any parting words, since this is your mastermind of people who you brought together and put together, I think that'd be wonderful. Before then, everybody give yourself a round of applause. You guys, thank you for coming. Experts, thank you. Family, don't rush out. You know, the experts are going to be around. They have their booths set up. Mingle for a minute. Ask your questions in private if you have a private question. So thank you for being here. Thank you for being a part of this. Dr. Ashley, you can wrap it up.
I don't have any parting words. I just want to thank all of these women. Their schedules are really tight with family, tight with work, all of it. The timing aspect, time is like our most valuable commodity. For all of you to give that up on a Saturday morning when you're just coming off a shift, just coming out of a labor, just coming out of a billion things that were happening on the home front. I appreciate you all for being here. If you can stick around, if you don't have to rush out for a labor, I know people would appreciate, obviously, to have more conversation if it's possible. Good? If any of you have anything to offer, like anything you want to offer, just this room, you're more than welcome to. So if you visit a table, I think we're gonna give savings on the first visit. I don't know if anybody's thought about that. I didn't email anybody that, but I was just thinking about it right now. You've already shared the experience, got insights. So if any of you want to offer anything, you can announce it from up here or have people come and talk to you out there. Anybody want to say anything?
We have a quick little
Go for it.
raffle. We pulled together, we received so many donations, so our 501c3 is donation driven, and we're selling them for pennies, but we're doing it to fund a literal family right now who's in her due window. So we're accepting donations and we're doing raffles for that, and then we also have some bath salts that you can customize with some doTERRA for a soap if you would like to get take that home with you. So
Anybody else?
Yeah.
Oh, sorry.
Sorry. On my table here in the back corner, there's little business cards with a QR code for half off a family style visit. If you don't have like a complex case, we can do like, sometimes we'll just see the whole family in 45 minutes and kind of get everyone going, which makes it infinitely more affordable. Or half off like a full comprehensive like complex case.
All right, Sprite.